So our speaker is Dr. Erica Marsh, and she told me that the only thing I'm allowed to say is that she's a doctor who cares about community and fibroids, but she is also a mentor, a friend, a partner, a supporter. She kept me from losing my job, y'all. We was gonna have a misunderstanding at University of Michigan, and she brought me back in. That's why I'm here standing before you today. So without further delay, I'd like to introduce you to Dr. Erica Marsh, my friend, my partner in crime and community, and all the wonderful things that she does.
Amen. Yeah. Thank you, Alfreda. I think, Alfreda, there's a little bit of a role reversal. Alfreda is my mentor, my friend, my partner in crime, and the reason why I haven't lost my job. So we keep each other on the fray. Good to see you. It's first of all, thank you for coming out on a Saturday morning to hear about a topic that's not fun, that's not sexy, but it's important for us to know about. As Elfrida shared, I'm a clearly directionally challenged, even with GPS, clinician and on the faculty at University of Michigan. I'm chief of the Division of Reproductive Endocrinology and Infertility, which means that clinically I spend a lot of time working with patients, most of whom identify, as women. So I'm going to use the word woman in my talk today. I want to acknowledge that not everybody born with a uterus self-identifies as a woman, but I will be using that terminology just for ease to facilitate moving forward with the talk. But most of my patients are interested in fertility. Not all of them, but most of them are. And many of them come to me with fibroids, the topic we're going to talk about today, and are being faced with having to make a decision about having a hysterectomy or not, and feeling like that's the only option that they've been given, and not feeling like they have a good understanding of the disease in general. And so today, during July, which is National Fibroid Awareness Month, I'm excited to share with you some information about this incredibly prevalent condition, to share some information with you about the significant health disparities we see with fibroids. Now, fibroids are a condition of most people who are born with the uterus. However, there's certain racial groups or ancestral groups, we're not sure kind of which, to be honest, if this is a genetic thing or a lived experience thing, or if it's a combination of the two of them. Most likely it's a combination, but there's certain groups who have higher incidence and higher prevalence of fibroids, namely folks of African ancestry or who self-identify as Black or African American. However, fibroids are a disease of everybody who's born with the uterus. Most people who are born with the uterus will have fibroids by the age of 50. Not everybody will be symptomatic from them. Many people will not even know they have them because they're small. They may only have one or two. But some women have 50, 60. And so we're going to talk about that condition, how it causes symptoms, why it causes symptoms, and some work that's being done in the field, and how all of you can be fibroid warriors, fibroid educators in your circles, in your families, in your social networks, because we need more information about this disease. Am I able to advance my slides, or? Do I need to turn? Okay. Do I need to turn it? Okay. So I'm going to talk because I have kept you guys here already, but I'll catch up with the slides. But what are fibroids? Medically, they are called leiomyomas. Okay, leiomyomas, and that's that top word. And when you look at the Greek and Latin roots for that, thank you so much. Appreciate you. It's smooth muscle tumor. So fibroids are smooth muscle tumors that grow in the wall of the uterus or the womb. Now remember, an unpregnant uterus or womb is typically about the size of your fist, okay? All right? So we're going to look at pictures and forgive me because I know y'all are eating or just ate, but we're going to look at some pictures as well. Because it's important that you kind of understand what these masses are. Now, I'm using the word tumor, and a lot of people, when they hear tumor, they think cancer. And fibroids, if it's a fibroid, it is not, by definition, it is not cancer. Now, it may not be a fibroid. There are some cancers that grow in the wall of the uterus, but fibroids themselves are not cancerous, okay? So they are well circumscribed, meaning the borders of them are very clear. There's some tumors that kind of mingle in with our normal tissue, and you can't tell where the diseased tissue ends and the normal tissue starts. But fibroids have very distinct borders. So when we see them surgically or on imaging, we can say, okay, that's the fibroid, and I know it starts here and it ends here. They can be single, so some patients have one fibroid. Some patients, like I said, have 50, 60 or more fibroids. When we cut into them, like that top picture is a fibroid that's been cut in half. We see kind of whorls of fibrous tissue. The bottom picture is also a whole uterus that's been cut in half, and the whole top of the uterus has been filled with a large fibroid. Okay, that white. I don't know if I can. Okay, all of this is fibroid. Okay, this is the cervix down here, and the uterine wall, the normal healthy uterine wall here, has been essentially compressed. Fibroids can be microscopic. They can be up to 100 pounds, okay? And they're composed of extracellular matrix. Now, we don't all need to start blaming our weight on fibroids. Most fibroids do not get that large, but they can get large, okay? And they account for up to $34 billion of expenses each year, including healthcare costs, missed work, outpatient expenses, surgical expenses. So they have a significant impact on our system, on our economy, and you can imagine on the economy of an individual that's dealing with symptomatic fibroids. Now, how do they present? Now, as I mentioned, some studies say a little more than half of patients don't have symptoms from fibroids. So that's probably the only good thing about them. So if you will often, many patients are told they have a fibroid, and it's found what we call incidentally. Maybe you're having a CT scan for a kidney stone, and they said, oh, by the way, you have fibroids. You don't need to, that doesn't need to be cause for shock and awe. Particularly if you're in your 40s or 50s, it's actually likely that you're going to have a fibroid, particularly if you're Black. They're incredibly common, but they don't, just because you have them doesn't mean that they're causing you problems or symptoms. The symptoms of fibroids really vary depending on where they are and how large they are. And typically, if you have symptoms, you have more than one symptom. And the most common symptoms are listed here. Abnormal uterine bleeding of the heavy menstrual bleeding subtype. Medically, we refer to that as AUB. Again, abnormal uterine bleeding. Pelvic pain, pelvic pressure symptoms, infertility. I will say recurrent pregnancy loss. So having a fibroid and having a single fibroids are not associated with kind of a single loss, okay? So if you have a miscarriage and you happen to have a fibroid, it's not necessarily due to the fibroid, largely because fibroids are common, and unfortunately miscarriage is a lot more common than we realize, okay? About 15 to 20% of pregnancies will miscarry. However, patients with recurrent pregnancy loss, so they've had 3 miscarriages, 4 or 5, and fibroids have been associated with that. So how do fibroids cause symptoms? Why do they cause symptoms? Well, just to review our anatomy, because we're not really, after high school health, we're not really taught about our anatomy anymore. Now this, if you can imagine a female standing sideways, and I just cut in half and open it up. So you're looking kind of inside from the side. This bone right here is my pelvic bone, or your pelvic bone, that hard bone in front, and this is my backside right here. Okay, so this is the uterus, and you can see the uterus is nestled between our bladder and our colon and rectum. Okay, so this is where we urinate, and this is where we poop. Okay, sorry. This is where we urinate, and this is where we poop. So if you have a fibroid that's on the back of your uterus and that fibroid grows, you might present with lower back pain. You might present with constipation. Now, just because you have constipation, don't run to your doctor and say, I must have fibroids because I'm constipated. Fibroids are not the most common cause of constipation, okay? But they can cause constipation. If the fibroid is in the front of your uterus and it grows, it's going to press on your bladder. What might you present with, or somebody present with, who has a fibroid pressing on their bladder? Frequent urination, exactly. So feeling like they have to go to the bathroom very frequently. Now, are fibroids the most common cause of frequent urination? No. A UTI is the most common cause. So if you're having that, the most likely cause is that you have a urinary tract infection. But if you check your urine and you're not having a urinary tract infection and you're feeling like you have a little bulge down there, it might be a fibroid, and ask your doctor about that. Some patients have a fibroid on their cervix, what we call a cervical fibroid. Those patients might present with pain during vaginal intercourse or bleeding during vaginal intercourse. So you can see, given the anatomy, the female anatomy, and where the uterus is nestled, depending on the number and size of fibroids, if the fibroid is inside the uterus, in the uterine cavity, it can cause heavy menstrual bleeding. Okay, because that's the inside of our uterus. This layer, this line right here, is what is shed every month during our menstrual cycle. And if you have even small 1 to 2 centimeter size fibroids in that area, it increases the surface area and causes you to bleed more. So this is a picture of a uterus. So just so you know that drawing is more than just a drawing, this is a picture of a uterus that is the size of somebody who's 28 weeks pregnant.
and a master of none.
Thank you. Thank you. I'm sorry. I didn't realize you guys. Please, if you can't hear me or can't see something, please raise your hand, because I'm just going to keep on talking otherwise. Before puberty, we typically don't see fibroids, okay? During that reproductive window, typically 21 and older. Sorry, I was just like, there's somebody behind me. When we see estrogen and progesterone levels increasing, that's when we see fibroids, that's when we see them grow, okay? And when do we stop making estrogen and progesterone? When we hit what? Menopause, exactly. So it can be, some of us hit menopause naturally. Some of us hit it surgically because we have our ovaries removed. Some of us think when we have our uterus removed, that puts us in menopause. That does cause us to stop having periods, but that's not what puts us in menopause. It is you're having your ovaries removed that puts you in menopause surgically, or we can be put in menopause medically by taking certain medications, namely medications that suppress that hormonal axis in us. Some of you may be familiar with the medication called leuprolide acetate. The common brand name is Lupron. That's a medication that puts you in a temporary medically induced menopause, and we give patients that and medications like that. We have some oral medications that work in a similar way now that we can give, not just injectables, to temporarily to put you in menopause. But what that does is it lowers the estrogen levels, and so we see shrinkage of fibroids when patients hit the menopausal window. So sometimes the goal is just to bridge you to menopause, because we know once you get to menopause, those fibroids should shrink and you shouldn't be developing any new fibroids, okay? Now, your old fibroids aren't going to shrink and disappear, but they certainly shouldn't grow, and you shouldn't be developing new ones. So much so that if you are postmenopausal, okay, and you feel like, oh, I think my fibroids are growing, you need to go to your doctor, immediately, because that's I would be concerned that it's something that's not a fibroid that's growing in your pelvis at that point, okay? So again, you shouldn't have growing fibroids once you hit menopause. So we know that fibroids grow in response to sex steroids, estrogen and progestins. There are many other things that make fibroids grow as well, but this is not a basic science talk, so I'm not going to go delve in there. But why do we do what we do? The molecular biology is important to researchers like me and to people like you who who might want to wave their nerd flag like I do and say, like, I want to understand this a little, to this level. How many chromosomes are in the fibroid cells? Are the fibroid cells different than my uterus cells? What is my uterus like with and without fibroids? But at the center of it all, we do what we do for the patient, okay? I, as a provider, do what I do because I care about patients. I care about women's health. I care about people who are born with an ovaries and a uterus, understanding their biology, our physiology, and our pathophysiology, meaning what happens in our bodies when things don't work the way they should. So I want to spend a few minutes talking to you about patient-centeredness, and you guys are actually the experts on this, so I don't need to be talking to you about it, but I want to share it with you because I think this is a space that we're really trying to expand, particularly when it comes to fibroid care. The idea of patient-centeredness, which we shouldn't even have to say, because if medicine isn't patient-centered, then what is it? But we're, we are all a work in progress. All our fields are a work in progress. And the Institute of Medicine, now about, it's more than 20 years ago. I remember when this report came out, I was in medical school. Now it's called the National Academy of Science, Engineering, and Medicine. But they're kind of a think tank that puts out a lot of important reports on medicine and healthcare. And they put out a report that contained the concept of patient-centeredness, which is that healthcare which is defined as healthcare that establishes a partnership amongst providers, patients, and their families when appropriate, meaning when that's what you want. Not everybody wants their family in their business, and not everybody wants their family in their business about every aspect of their health. But when you do want your family and friends involved, you should be able to be in a healthcare setting where they are welcome and they are included in your healthcare decisions to ensure that decisions made respect what you want, meaning what our patients want, what you need, what you prefer, and that you have the education and support that you need to make decisions that are best for you and to participate in your own care. So rather than being told what to do, you get the information, sufficient information, and information in a way that you can understand it and you feel empowered to make that decision. Now, some of us may still say, doctor or nurse or physician's assistant or midwife, I hear what you're saying, and I think I understand most of it, but I want you to tell me what you recommend. And that's okay. That's okay. Your healthcare provider has had years and years of training, and you want their opinion. You want them to weigh in, but you don't want people telling you what to do when you feel that it is not in your own interest or aligned with your own life goals. So a shorter way to talk about this is the right care in the right way at the right time, or even shorter, nothing about me without me. So my perspective as a provider might be, medically, okay, my patient is a 43-year-old G3P, G4P3, meaning she's been pregnant 4 times, she's had 3 children. She has a 24-week size uterus with fibroids. She's told me she's done having kids, but she's having heavy menstrual bleeding and she's having bulk symptoms. The best treatment option for her is a hysterectomy. That is a reasonable treatment option. It's the only definitive care or option we can offer this patient. But the patient might be in this space, and this is a quote from a qualitative study that I conducted. And qualitative means it's interviews. It's just talking to people and asking about their experience with fibroids. And this is a quote that I thought was simple but so powerful and eloquent. They viewed my uterus like it was a useless organ. They said, well, why do you want to keep it? And I said, because it's mine. Now that's a mic drop moment. That's like end of period, end of sentence. No, thank you, I have some, thank you, but please excuse me for 1 second. Thank you. All my aunties are over there. My community aunties, and I need them. My perspective may be, okay, this many fibroids, let me measure them, let me weigh them, so I know how to bill correctly and I can bill in the right category. But this is what the patient is experiencing. So this is what we call a word tree or word ball in this case, where we took interviews from about 60 patients with fibroids, and the size of the word is based on the frequency of how frequently that word was mentioned. But you look and you see words like, period, pains, surgery, bleeding, goodness, myomectomy, meaning the surgery where just the fibroids are removed, pretty, ultrasound, hoping, cramps, hospital, relationships, bathroom, research, diagnosis, embolization, pregnant, baby, pretty. you know, it's not bread and butter for a patient. When you're going through it, things that all of a sudden look simple and sound simple in a textbook are not so simple. So we know that fibroids not only are complex in terms of all of the things coming at you, but they have emotional and psychosocial impact. This is a paper that I wrote with one of my mentees now, gosh, I can't believe we published this 8 years ago. It feels like I was going to say 3 years ago. Woo, time is flying. But we again, interviewed about 60 patients with fibroids, and almost 100% of them reported some level of psychosocial stress, okay, or distress. About half of them said they felt hopeless when it came to their fibroids. About a third of them said that they felt negative about their sexuality or about their bodies because of their fibroids, and about a quarter of them felt like they had a lack of support. This is a quote from one of the interviews: "Tired, emotional, and depressed. All of this has caused me to be depressed, and it makes me feel inadequate." None of us should feel that way, okay? We also know that there's a significant treatment delay in patients that have fibroids. It takes a while to get them diagnosed, and once the diagnosis is made, it often takes years for patients to feel comfortable engaging in a treatment protocol that they feel comfortable with, that they feel like they understand the risk and the benefits of, and they feel like allows them to still achieve the life goals that they want to achieve. So a lot of the rationale or the reasoning for the the delay in treatment was what I call an altered state of normal. So when as your fibroids start to develop over time, and they grow slowly, typically, all of a sudden you don't realize that your periods used to be 3 to 7 days, and now they're 2 weeks. Now they're, or they went from 3 to 7 days to 10 days to 13 days to 2 weeks to 21 days. And this is another quote: "My period lasted for 30 days, and it was heavy and it was horrible. I was wearing pads like the size you get in the hospital after you have a baby, and I was so used to that happening that at the time I didn't call anybody because, it was like, this is normal." When your mother had these kind of periods, your sisters had these kind of periods, your aunties had these kind of periods, you start thinking like, well, isn't this what everybody's period is like? Isn't this what a period is supposed to be? And if you don't know that the normal, a normal length of a period is 3 to 7 days, then you don't know that a 14-day period is too long, okay? They're gonna take the remote control away from me. Again, an altered state of normal. I have always had pain during sex, and it was funny because Dr. X, we blocked out the name, this is one of the folks that we interviewed in this same study, asked, and I was like, no. And then I went home and I was like, yeah, I do, but no one had ever asked me that. It never occurred to me that other people don't have pain during sex. This is not to say that all pain during sex is from fibroids. That's not the case. But depending on where the fibroid is, it can cause pain. It can be associated with pain during intercourse. We have to do better about what we think is normal and what we think is acceptable as women. Limited knowledge was a challenge. No, I had not. With a bachelor's degree, now we removed the expletives from this person's interview, but she was really upset. She's like, with a bachelor's degree and a master's degree in science and chemistry, I had not. When we asked, had she heard about fibroids? Thinking back to anatomy and physiology classes, we talked about having babies, talked about different forms of cancers, but did they ever mention a fibroid? I don't think so. avoidance-based coping strategies, just again making ourselves satisfied with the way things are. This is just what you go through as a woman. It was like every month you're going to bleed half to death, and then the rest of the time you're almost okay. I just went with that because, you know, it didn't kill me, so I would just be stronger. Now, come on. We gotta do better. We gotta have a higher bar of expectation for ourselves, for our loved ones, for our lives than this. And there's, you know, this is why I like doing qualitative work, because of the power of the message. The power of the patient's voice is undeniable. Now, might we need to design a quantitative study to dissect this a little more? Sure. But the ideas, the concepts, the themes that come through in this type of research are really important. First of all, we have to start getting comfortable with the menstrual cycle, the fact that we have periods. There's a lot of language that has been used societally, particularly in Western culture, to make us ashamed of our menstrual cycles, of the fact that we menstruate. The nicknames that you hear that it's given: on the rag, friend in town, Aunt Flo's come to visit, or Aunt Ruby, the Red Sox have a home game, the dam has burst, or the curse. You know, we have to kind of own the fact that this is part of our physiology, and you know, the what we call the products that we use. Protection, sanitary, hygiene, as if there's something dirty about having a period, as if we have to be protected from our own bodies. Words matter. Words matter, and so none of us invented this language, but we live with this language. We use this language, and this language imprints on how we think about processes that are completely normal. We menstruate. That's the evolutionary imprinting, so that we can procreate, so that we can perpetuate the species. Okay, menses is part of the process we go through to release an egg to see if it's going to fertilize an implant for pregnancy. Now, the vast majority of our menses, that doesn't happen. But the menses is an incredibly beautiful symphony or orchestration of hormones talking to distant body organs on, is she pregnant? No. Okay, let's mature egg. The egg is mature enough. Let's release the egg. Oh, did the egg fertilize? Let's get the endometrium, let's get the womb ready, just in case the egg fertilizes and implants. Oh, didn't fertilize? Okay, let's shed that endometrium and start the process over again. That's what our menstrual cycle is. Okay, that's why we do it. Do you have to menstruate every month? No. It's not harmful not to menstruate every month, but it's so if you want to there are a lot of products now, a lot of particularly contraceptive products where you can have fewer periods a year, or eventually stop having periods altogether, and that's okay. That's not harmful, but just to give you the background of why that happens. Now, getting back at who gets fibroids, if you're born with a uterus, you have a good chance of having fibroids, okay? So risk factors, though, include race, being overweight, having high blood pressure, having a history of a pelvic infection, alcohol consumption, specifically beer, are all associated with the increased risk of fibroids. Parity, so having a number of childbirths, deliveries, as well as smoking are associated with a lower risk of having fibroids. And we're going to talk about race a little bit, and the topic of health disparities. So broadly, health disparities are differences maybe in the incidence or the prevalence or the mortality or the morbidity or burden of disease and other adverse health conditions that exist among specific population groups in the United States. And this is kind of the broad umbrella definition. What we get most concerned about within that are the health inequalities. So those differences which are not only unnecessarily, but the ones that we can avoid, in addition are considered unfair and unjust. Okay, so how does inequality play out in our healthcare? Well, let's look here. Let's imagine two little children, identical except for what color T-shirts they have on and what color backpacks or jumpers they have on. And they run up to a tree, or they're plopped down in front of a tree just randomly. And one is plopped down in front of the side of the tree that's leaning toward them, that has more apples on it and is closer to them. And one is plopped down on the side of the tree that has much less fruit and is leaning away from them. So if we start from a place of inequality, meaning unequal access to opportunities, where do we want to get to? Well, is equality where we want to get? Do we want evenly distribute tools and assistance fix inequality? And this is an example of no. A lot of people are like, well, how can that be wrong? Why not just give everybody the same thing? Doesn't that fix the problem? The answer is no, not only does it not fix the problem, it actually exacerbates the inequality, because it often puts the group or individual that started out in a better position at an even better position, and it still leaves the group that was disadvantaged. So what are we working toward? We want a system of equity, again, where we're addressing the inequalities appropriately. And so this little kid has a ladder that gets them up to the tree, and this little kid has a ladder that gets them up to the tree. Now, is that still right? Well, no. The tree is still, why does one have to climb up a higher ladder? Why is one on the side of the tree that has less fruit? We ultimately want to get to this place where the tree is straight, where there's fruit on all sides of the tree, where we can actually go back to this model of now we can give everybody the same thing. And it's really the only thing that's determining your success, your benefit, is, are you willing to reach up and grab the fruit? Are you willing to do the work that it takes to reach up and grab the fruit and fill your bag with apples? That's ideally where we want to get. And how does that play out in healthcare, though? Why are you showing us some cartoons? What does that have to do with healthcare system? Well, what are our bins in our tree trunk, okay? They're social determinants of health. They are, our economic stability, our physical community, meaning housing, transportation, how safe we feel walking out of our homes, our education level, our general literacy, our health literacy, language, vocation, higher education, food access. How often are we hungry? How often do we have access to healthy options? When I go into a store, is a pack of bottled water 4 times as expensive as a 12-pack of pop, of soda? Then guess what? I have this much, I'm gonna get the pop. Is the ground beef a whole lot less than the filet chicken breast? Yeah, it is. I got to get the 80%, lean ground beef, and not the filet mignon, and not the chicken breast. If I have limited resources, and if that assumes I know which is healthy and which is not, or healthier or which is not, which is a big assumption. Then ooh, Lord, I'm gonna get put out. Okay. This is our physical community, but what about our social community? How supported do we feel? How engaged are we? What type of discrimination or chronic stress or early stress are we, or routine stress are we dealing with? And then, of course, healthcare system, our access to healthcare. So those are the bends in our tree, the things that, if we're dealing with, can put us at a disadvantage. And that's not unique to a certain gender. That's not unique to a certain race. That's not unique to whether you live in an urban area or a rural area. Though these factors impact many of us. Some of us more disproportionately than others, but they impact, we are all impacted by, or at risk of being impacted by these things. So what's the fruit? What are we reaching up for that we want access to? Well, we want autonomy, meaning we want to be able to determine what's best for us. In the case of fibroids, if I have a choice between a procedure where I have to stay, I can go home the same day and I'm only missing 2 weeks of work versus I have to stay in the hospital 4 days and I gotta miss 8 weeks of work, I want the minimally invasive option. For some patients, not everybody, for some patients, having the ability to have a family, to keep their uterus is important. And at the end of the day, it's about living your best life. So I'm actually going to, I know we have some questions, and but I also know that we started late. So these are just some slides that I'm gonna kind of skip that really talk about the differences in race, the racial prevalence of fibroids, as well as the fact that fibroids start earlier in Black women than they do in white women, significantly earlier. So those prevalence rates are much higher in Black women who are in their 20s up to 30 versus white women. We also know that there are differences in treatment outcomes with Black women in terms of fibroids and in terms of invasiveness of procedure, risk of complications, that type of thing. And that our knowledge is in our community is not what it needs to be, and that we need to invest in learning about our bodies and ourselves. And this is a study that was just looking at African American women in Chicago, but I don't think that this is the lack of familiarity or knowledge about our bodies and our reproductive health. I don't think that is unique to one community. I think as women in general, we're not taught about our physiology the way at a level that we should be, and that's something that we have to change. So in summary, yes, African American women have a higher prevalence of fibroids than Caucasian women or white women, but fibroids are a disease of anybody born with the uterus, and I will say anybody born with the uterus has a high chance of having fibroids. Remember that just because you have fibroids, that doesn't mean you need to run and take medicine for it or run and have a procedure for it. If the fibroids are not bothering you, if you're not having symptoms from them, if they're not damaging anything else around them, then you don't need to intervene. If the fibroids aren't bothering you, you don't need to bother them. There are a lot of potential biological, behavioral, and social contributors to this disparities, and that remains an area that many of us, myself included, are continuing to investigate. So with that, I will end, and I'm happy to take questions or proceed with the program. I want to thank you, Alfreda, and your team of Community Health Services for inviting me, for sponsoring this event, for helping us celebrate Fibroid Awareness Month. And I want to, again, thank all of you for your kind and generous attention and for waiting patiently here for me while I got a tour of Ypsilanti this morning. Take care. Bye-bye.
Hello? Yep, it's working. So we had a couple of questions that were populated. First of all, thank you, Dr. Marsh, so much for the information that you shared with us. You know, before you got here, I was saying that what's the important part about this is that we tell somebody else, and we have conversations in our family about what our medical history is. I read an article a long time ago where this one family of women would sit down and talk about all of the things that health-wise that was going on in the family. And it just made me think about the fact that our mothers, our sisters, our cousins, somebody could have it, and because, as she said, it just seems to be normal, we don't talk about it. And so we should be talking about everything health-wise so that we know what's going on with our bodies and being better stewards of our bodies. I also want to thank Ellen Bust, who is a project manager for Community Health Services. She's the one who put this whole thing together. She just lets me rattle on her coattail. She does. Dan Zimke, who is our marketing program manager extraordinaire. We wouldn't, the anemia screens, I want to remind you, if you haven't got your finger pricked for your anemia screens, I'm going to say your name, Trish. Trish just be worried. She be bothering me, y'all. She just be on me, okay? Don't forget to get your anemia screen. So I want to thank Trish Rowley, who is our clinic coordinator, our community clinic coordinator. Her husband, I call him Mr. Honey, but his name is Tom. For being the person that brings all of these things and sets all these things up for us. And then I also want to thank the Association of Black Nurses and our chapter for being here. Winnie Woods, and I'm going to mess up Miss Leggett's first name, so I'm just going to say Miss Leggett, Nurse Leggett over there. So please go over and get that done. And so one of the questions that we had this morning was, are there any natural, yes, you may, are there any natural treatments for fibroids that you can do to reduce your fibroids?
There are no natural treatments that have been confirmed in what we call randomized controlled trials, which is the best kind of study we can do to really determine if a treatment works or not. You know, I come, perhaps like many of you, I grew up in a family that relies on you know, where stories are passed down of what works and what doesn't, where I was given stuff that I'm surprised didn't kill me when I was a child. And, you know, but, you know, and sometimes it worked. And sometimes it worked, but you know, it's not, the difference is it something that I would run out and tell everybody to start taking? Probably not, you know, probably not. And, you know, are there things that we can take that are natural to help us feel better during our fibroids? Absolutely. If you are anemic, your hemoglobin level is low, eating dark green leafy vegetables, taking an iron tablet once a day or once every other day. We used to tell people to take 3 iron tablets a day, and, you know, but we know that actually we can't even absorb that much iron, and it just kind of goes through us. So, you know, take an iron a day, preferably with some orange juice or grapefruit juice or lemonade, something acidic that will help the absorption. or if you're open to eating, eating a serving of red meat, that's a, can be a natural approach to improving your iron. Is there anything that's been shown that you can take naturally that's going to shrink fibroids? No. They're not from a research trial perspective. We wish that there was. I think all of us prefer something natural, something minimally invasive, something earth generated versus generated from in a factory somewhere. But there hasn't been anything that has been shown that can naturally shrink fibroids.
And so then the next question, and Ms. Monique, you may have to help me on this and make sure I got it right. If your doctor examines you in your 20s and finds that you have fibroids, what are the next steps for you? Oh, I missed something.
Have no fibroids.
No fibroids, no fibroids.
You have symptoms that suggest maybe fibroids.
But examines you and says you have, I don't see any fibroids. But you feel there's something going on. What should you do? What are your next steps?
A bimanual exam is that's the exam that that women have from either their primary care doctor or from their OBGYN that tries to assess the size of the uterus. That's the goal of that exam. We don't often tell patients what we're doing or why we do it, but just so you know, when a doctor has hand in vagina and hand on the top of the stomach and is pressing, we are squeezing, trying to feel, okay, how big is this uterus? Now, some fibroids don't increase the overall size of the uterus because maybe they might be inside or in the wall, or, we can't, our bimanual exams are good, but if it's a 1 centimeter fibroid, we may not be able to feel bimanually and detect that. If you're having, let's say the symptom is heavy menstrual bleeding. If you're having that and the doctor says, well, I did a bimanual exam and I don't feel anything, it's reasonable to say, well, should I get an ultrasound? Should I get something that's going to do imaging? Your doctor may have reasons why they don't think that's necessary. Let's say you just had an ultrasound a month ago. They're like, well, they may say, well, you just had an ultrasound a month ago that I went back and looked at, and you didn't have any fibroids then. It would be it would be rare or very unusual for you to have grown one in a month. That's a reasonable response. But if you've never had imaging and the doctor's just going on a biannual exam, you may want to ask, is imaging appropriate? I don't want to get into giving specific medical advice in these settings because that wouldn't be appropriate. I don't have all of the information that I would need, and I certainly don't want to presume that any other provider is not doing the right thing. But in general, a bimanual exam is a very reasonable first step. And imaging is often the next step. So it might be ultrasound. Sometimes a doctor may say, well, let's get an MRI because I see fibroids on ultrasound, but your fibroids are so big that the ultrasound actually can't see your whole uterus. So I see a lot of patients for whom I have to order MRI because they have 30-week size uterus, 40-week size uterus. And I need the capability to see, up to here and not just down in the pelvis.
So those were the two questions that we gathered from the audience before Dr. Marsh arrived. Are there any other questions? Oh, yeah, I didn't write that one down. Yes. It was, all right, I told y'all I was old. That was your question.
Determined. what is the age or the youngest age that our young women should be concerned about fibroids? I know you had a slide up here that you had 21 to 24. Is it younger than that? Could it possibly be younger than that if it's family history? But when should we start looking or really paying attention?
Absolutely. So one of the slides that I kind of blew through at the end really quickly that probably would have helped answer that question is a lot of it. I mean, first of all, statistics are statistics, studies are studies, but we're all kind of our own cases. When I did a study in Chicago that I showed the data from, where I looked at 100 young women between 21 and 30. Half were black and half were white. And I focused initially on black and white women because that's where the subsequent, those are the only two groups where we had expanded data of 35 to 50. So let me start with that, and then I'll talk about other groups other racial and ethnic groups that we've looked at. So when we looked at 21 to 30-year-olds, there were, 18 to 30-year-olds. Nobody, black or white, had fibroids between 18 and 21. Black women started to have fibroids between 21 and 23. Overall, in that age group, so that young cohort, 26% of black women had fibroids and 7% of white women had fibroids in that very young age group. So in general, my experience as a physician, and I've been a physician for 22 years now, is that I have not seen fibroids in patients under 20. That doesn't mean that never in the history of the universe has that happened. Okay, I'm not saying that. I just have not seen fibroids in patients under 20. We know that fibroids respond to estrogen and progesterone. In general, our late teens and our early 20s is when our menstrual cycles, we start menses at 9, 10, 11, 12, but it is not until our late teens until our menstrual cycle gets itself together and actually says, okay, I'm on a 29-day cycle now, or I'm on a 30-day cycle, or I'm on a 28-day cycle. But in our teen years, our menstrual cycle is typically a little erratic because it's trying to figure itself out. Now, what data do we have on other groups? The reality is that it's very little. One of my NIH-funded studies that I looked at, let me take a step back. So most of the data that we have on Asian women and Hispanic women in particular comes from big studies like the Nurses' Health Study. Nurses' Health Study 1 and Nurses' Health Study 2 in particular. And it shows those studies were not powered to look at Hispanic and Asian women. And largely because of that, they say, well, there's no difference between Hispanic and Asian women and white women. Okay, so all of a sudden in medical school, we're like, well, it's white and black. Those are the two differences. But when in reality, we haven't studied Asian women. We haven't studied Hispanic women. We haven't studied Arabic and North African women. We don't know for sure. So one of the things, when I was still in Chicago, I saw a ton of Latina patients and who had fibroids. They came to, I got a reputation for being the fibroid doctor. And they're like, what are these? How prevalent are they in my community? What are my chances of them coming back? And I went to the literature, and there's no literature. And so I was like, we have to make sure that we are all present in the literature. There's so much of medicine that is based on men, okay? And then we finally realized, like, okay, we actually need to include women in studies, but it was men and white women initially. And now we're like, okay, well, we need to look at a broader group, and so it is expanded to white women and black women. And now NIH is saying, okay, we need to look at all groups that are, or study cohorts that are representative of our makeup in the United States. So we need to include white women, black women, Asian women, Hispanic women, Native American women in these studies. We're not there yet with fibroid research, amazingly, in this incredibly prevalent disease. We're not where we should be, but we're getting there. And so the short answer to your question is, if you're in your 20s or older, I think it's very reasonable, and particularly if you're black and in your 20s or older, I think it's very reasonable and you're having like heavy menstrual bleeding, you can consider fibroids in the differential. In your 20s, would fibroids be at the top of my list for cause of, say, irregular heavy menstrual bleeding? No, it wouldn't, but it would be on the list of things to consider. If you were, the same is true if you weren't black, but I would say fibroids would be even lower on the list of things that I would consider if you're having a sporadic heavy period or even regular heavy periods in your 20s.
My question is somewhat related. At what age, if you're African American, should you start going to a gynecologist? So my daughter, she's 32 now, and recently was seen by a gynecologist, but it was a result of her internist saying, oh, the heavy bleeding, the symptoms that you're experiencing are not a result of fibroids. Then she ended up going to the hospital because she was having some other symptoms and was told, you really should be seen by a gynecologist. So I'm wondering, at what age should women be seen by a gynecologist, in addition to going to their internist or physician?
I am a OBGYN, okay? So I have a inherent, I potentially have a professional bias here that I just want to disclose, okay? I think that if you have a gynecological problem, meaning a problem with your periods, with your pelvic organs, with your pelvic area, it is appropriate to consider going to an OBGYN at any age. I have colleagues that specialize in pediatric and adolescent gynecology, okay? Let's say you don't have any problems though, and you're just, which is most of us. Most of us kind of get through to adulthood, reasonably intact. I think when you become sexually active, it is helpful to start seeing a gynecologist regularly. Certainly when you become pregnant, you need to see an OBGYN. Or a certified nurse midwife. I think there's many specialties that provide gynecological care. My bias is that OBGYNs are really, are the best people to provide gynecological care. But the reality is we live in a state that has more veterinarians than OBGYNs. So not everybody has access to OBGYN. And we have some incredible colleagues in other specialties that are on the front lines providing that care, and I am grateful that they do that. I am truly grateful that they do that, because otherwise women who wouldn't be getting pap smears or breast exams. Are they going to be able to do a bimanual exam as well as I can? Probably not. And I can't look in anybody's ear anymore as well as they can. I'm like, you don't want me looking in your ear now. I'm going to be playing with the otoscope okay, I think there's a light up here. Don't let me come Medicine is so specialized now. When my grandmother turned 100 a couple of months ago, and I love listening to her talk about her experience with healthcare and how there were general practitioners. You went to one doctor that did everything. There wasn't, now she goes to 27 different doctors. And loves it. That's her social activity. That's her calendar. It's just like, we talk, and I talk to, my aunt that takes care of her every night. I'm like, my two questions are, what do y'all have for dinner? And what doctor's appointments did Nana have today? And because everything is so specialized, we know so much more about medicine now than we did 50 years ago, 100 years ago, that one person can't keep all of that in their head and do it well. So my feeling is that if you can get to an OBGYN and you're sexually active, and you may go and the OBGYN might say, you know what, why don't we touch base every other year as long as you're good, as long as you're not having symptoms. But it depends, are you interested in having an in-depth conversation about contraception? Do you have other medical conditions that may impact your reproductive system? I think those things may push you to get care earlier versus later, but I typically think it's very reasonable to start to at least have an initial new patient appointment with an OBGYN in your 20s. I know that's scary for a lot of young women because things are unsaid or undiscussed. I vividly remember, my first period and my aunt like whispering to my aunt, my mom whispering to her, calling all of my aunts and saying, Erica, and I was like, oh my God, what happened? And, it was like, oh, okay, what's going on? And sitting down and having the talk with me. And, my dad walking by and patting me on my head and walking out of the room. I was just like, did something happen? But there was never a discussion of you started your period. This is what that means. This is, these are the things, my mom did, we had this is how you need to take care of yourself during that window. But that was it. That was it. Until I got to, I had a few health classes in high school. And I was a curious and nerdy kid, so I read, much to my parents' chagrin, and I was just like, okay. But it can be intimidating going to a gynecologist when you're in your 20s, but I think it's important to take that ownership. And again, you may not need to go every year at that point in your life, but I think that continuity of care when things are normal is actually important. So when things become abnormal, you're not meeting a stranger to talk about it. You're going to your OBGYN who knows your body, who's done your bimanual exam, who's followed your cycles, who's done your breast exam, who's had the discussions with you, who's looked at your cervical cultures, who's done your paps. So when something changes, they can have those talks with you as somebody who is familiar to you and you are familiar to them.
Thank you very much.
Mm-hmm.
Please join me again in thanking Dr. Marsh for her talk today. It was something that everybody can take away. And remember, each one teach one. Don't keep it to yourself. Tell the rest of the world, the rest of your community about it.